Thank you everybody for joining us today for interoperability and information blocking, demystifying the next stages of the Cures Act. We're very excited to have everybody here today. We're sorry that some people weren't able to join us today. Obviously, the news of Hurricane Ian down in Florida, obviously that's impacting a lot of people in that state right now. So luckily, one of our panelists here was able to brave the weather, and we'll get to him soon enough. But let me start off by going through our agenda and introducing you to our great panel here today. We're going to cover sort of about 6 or 7 topics related to the Cures Act. Depending on our conversation, it may go sort of all over the place, but these are the things we kind of want to be able to deal with. Number one is talking about interoperability. Second thing is the Cures Act and the deadlines related to the Cures Act. We really want to focus in on the designated record set, and we'll talk a little bit more about that. And then the big thing here is going to be the practical advice and the culture of collaboration. And then we'll talk a little bit about what comes next and get to your questions as well. Talking about that Q&A, if you have any questions at any point during this webinar, please go to your questions and answers tab somewhere around here on your screen. And when you're sending a question, also make sure you let us know if there's a specific speaker you want that question for. If not, we'll try to figure out who's the best speaker for it. If you happen to put it in the chat section instead, that's okay. We'll figure it out and we'll sign it. You'll also see a couple of polls that'll come up during the session. Would love for you to fill it out. If the question isn't relevant to you, feel free to either not fill it out or put the not applicable selection. If it is applicable to you, please fill it out. We definitely want to be able to find out more from you and to be able to sort of address more of the things that you're interested in. It affects you more. So without further ado, let me introduce you to our fantastic panel. I should probably have introduced myself first, but I will introduce you to this group and then I'll just say a few words about myself as well. So first up here, we have Jonathan Friesen. John is the Chief Privacy Officer at Geisinger Health System, a central Pennsylvania-based system serving 46 counties, employing over 24,000 employees, and spanning 10 hospital campuses and 130 primary and specialty care sites. John completed his JD at the University of Colorado in 2009 and subsequently worked for the U.S. Department of Health and Human Services, Office of Civil Rights. He also worked at Kaiser Permanente prior to joining Geisinger in September of 2020. Next, we have Debbie Primeau. Debbie is Primeau Consulting Group's founder and president and leads the consulting practice in providing regulatory compliance, information governance, HIM staffing, and auditing services. Debbie has held positions in ambulatory care, acute care, and has worked with large consulting companies. She's an FAHIMA Fellow, past president of the California Health Information Association, received the CHIA Distinguished Member Award in June 2013 and Industry Champion Award in June 2018. And she is currently the chair for the FAHIMA Commission on Certification of Health Informatics and Information Management. And for those of you paying attention at home, that's CCHIIM. All right, next up, we have Kelly McClendon. And Kelly McClendon has been an HIM practitioner for over 43 years. He has a HIM credential and one for privacy and security of electronic healthcare records, a specialization he has held for as long as those concepts have existed. Kelly is a founder of Compliance Pro Solutions, where he helped design a software product which manages and automates HIPAA privacy, security, and many other areas of compliance. A frequent thought leader, speaker, and author, Kelly was awarded the Innovator Triumph Award by FAHIMA in 2015, among numerous major industry major industry awards over the years, something along those lines. And last but not least, we have Harsh Singh. As the General Manager of Healthcare at Genzion, Harsh is responsible for leading the Genzion healthcare practice, including specific practice areas in intelligent automation, interoperability, and risk adjustment. Prior to Genzion, Harsh had spent the last 20 years focused on removing inefficiency by utilizing technology, process, and business model innovation in healthcare, with leadership roles for Fortune 500 companies and SaaS startups, including Aetna, Anthem, and Crankfrog. My name is Alex Lucas. I'm the marketing manager here at Genzion, and I am mostly just the MC here and the moderator for this debate, but I'm very glad for all of you to join us. All right, so I'm going to tell you a little bit about who you are. At least that's what we've found so far. Based on your titles, we see that there's a lot of HIM folks, a lot of compliance folks, a lot of privacy folks. Not really surprising considering part of our panel here, but that's only about 2/3 of the people that are on this call, or we also have a sort of a smattering of a bunch of other people involving consultants, strategy, IT, security, basically, the Cures Act involves everyone within both provider organizations, within payer organizations, within HIEs, within vendors. So this really is something that obviously can appeal to a lot of different people. If there is something we're not talking about as much in this webinar, please, please, please definitely send us a note, either in the questions here or afterwards, and we will definitely be able to get back to you and try to get you more information. So what is interoperability? Not a fax machine. Now, granted, this is partly a joke because we're mostly talking about electronic, and we're thinking about sort of our paper records in the fax machine. So we're really talking about our health records. And so what health interoperability is, well, we have a definition here on the screen from HIMSS. It's really about accessing, exchanging, and integrating and using data in a coordinated manner. That sounds great, but what I'm going to do is kick it over here to Harsh for a second. We've been talking about healthcare interoperability for a long time. Healthcare has been struggling with it. Can you just sort of give us a little bit of a, sort of background, a real quick background on what are some of the barriers we've seen in the industry, why interoperability isn't here already? I think you're still on mute, Harsh.
My apologies, Alex. Hey, thanks for the question. I think one of the things I'll say is, interoperability in general terms, is what you mentioned, is exchange of data in some sort of a standardized and coordinated fashion. But we are focused here on clinical data interoperability, and in that context, we've been on this journey for a while. I would say, 10 plus, maybe even more, number of years. And when you talk about interoperability, one of the things you'll hear a lot about is regulations that have been pushing interoperability for the longest time, making sure the data is electronic with meaningful use regulations, making sure the data is standardized, as folks have seen standardization evolve over time from HL7 version 1 to many various versions after that, and now onto FHIR. And I would say the primary challenge around interoperability has been a broad adoption of those standards across the whole ecosystem of healthcare. And you will see and hear about these words that you'll probably hear from me specifically when I talk about folks choosing the path of minimum viable compliance on regulations. And I think part of it is a technology challenge, but part of it is an adoption challenge across the ecosystem. And I think we feel that we are coming to a stage here now where the data is already electronic, the standardization has happened onto the clinical data set. Now it's a matter of adoption across the ecosystem, and I think we would start to achieve the value prop that everybody's been waiting for. To the point of where we are in that interoperability, if you put up this slide around structural and semantic interoperability as level 2 and 3, I start to feel like we certainly achieved structural interoperability. The data structure that defined is well understood. If adoption happens, we would essentially achieve semantic interoperability across the ecosystem. I think right now we're between level 2 and level 3 of what I would refer to. But the panelists who are deep into this at Geisinger, and Debbie, with you as you support various organizations, and Kelly as a practitioner, you will probably have more to say on these topics. But I would tell you that as I talk to clients, that's where I feel right now we are with Interop. But quite an exciting place to be, and over the next 18 months or so, a lot to achieve.
Kelly, you're on mute.
My apologies. Yeah, thank you, Harsh, and I would agree. I think as we adopt, and this really isn't my specialty to understand these levels, but I would suggest that a lot of the organizational interoperability, as you read through it, non-technical considerations such as policy, social, legal, and organizational aspects, as we adopt in the Cures Act, what we're talking about doing, we're going to be meeting that too. So I think we're going to close the gap pretty well towards the end of at least the first phase of the interoperability journey. Once we get the Cures Act implemented with the FHIR interface and APIs, figure out our processes, get it into policy. All of that's going to take a little bit of time, but probably part of the adoption process.
I'd like to add that I think there are different stages of individual facilities and organizations at this level, because the smaller facilities are really struggling to be able to meet some of this interoperability requirements, where some of the very large systems seem to be right on top of the edge of it and are ready to move forward. So it is a challenge for those smaller organizations to be prepared. They just don't have the resources and the expertise, not necessarily, to move things forward as they will. So I think that's part of the challenge.
Yeah, you know, in actual practice, single physician practices may have it a little easier than, you know, community or smaller hospitals, in that, you know, if you're a small practice and you're completely reliant on your EHR vendor, and your EHR vendor can deliver the functionality and you can make the process changes required, which may not be that great for you, and that single physician office might be easier than managing through what hospitals have to do on the smaller end of the size scale. I mean, it's always a challenge. Jonathan's got endless stories about already what's going on with implementation in large complex facilities, but in the smaller ones, it's just going to depend on your size, who your EHR vendor is, what they have available, what you can afford, things like that, I think are going to enter the picture on the smaller end of the scale.
And I think we've identified that some EHRs are further along in the process than others. And so it does make it a little bit more challenging for some of these organizations that may not be a part of a large Epic or an Ocean supported EHR. So I think that when you look at the EHRs, some of these older ones or smaller ones seem to be struggling to be moving forward as quickly as the very large Queen Marys of the world.
And that's certainly the experience we've had, you know, at Geisinger with, you know, we are an Epic customer on the clinical enterprise side. It has been relatively, from a tech standpoint at least, easy to implement, you know, using sort of standard Epic tools. I think, you know, some of the challenges that, you know, probably your very small practices may not actually, you know, deal with, that larger systems or community hospitals deal with, are cultural, and, you know, ensuring that in your journey you're not forgetting, you know, those of us in compliance who are telling everybody, here are the rules and, you know, here's what you need to do to follow them, that we're making our providers, our patients, you know, all comfortable with the new accessibility of records. So we did, you know, at Geisinger, as part of our long-term project, and, you know, put together a steering committee and got our policies all together, you know, as we moved towards implementation. And one of the advantages, at least that we had as a system, is that we've long had, you know, embraced technology and access via, you know, patient portals, and had expanded, you know, pretty close to the US CDI, you know, set of records long before, you know, probably by 2014, we had, you know, essentially gotten to most of what was required in the US CDI, but with, you know, large sort of pockets that, you know, were not required at the time and are now going to be required, such as, you know, your pathology, your behavioral health providers. You know, there are pockets within these organizations that are particularly, and I think with good reason, sensitive to all sorts of privacy concerns, as well as, you know, potential emotional distress that may be caused by immediate release of results or immediate release of notes, you know, from a behavioral health session. you know, obviously, hopefully people are discussing challenging things in there, and, you know, it is concerning to these providers to release it. You know, so we spent a lot of time culturally, you know, reaching out to those departments months in advance of actually putting those notes out there, or putting the results out there, explaining why we had to do it. You know, the government had essentially came in and said, you no longer get to decide. It's out of your hands, which was, you know, from a compliance standpoint, is sort of a nice hammer to have. You know, we can throw the federal government under the bus if anyone's unhappy with it. But you know, I think in creating sort of FAQs that were designed per department, you know, for those more sensitive areas, creating FAQs to go to patients, as well as putting in, you know, we use our patient portal is the Epic MyChart tool, and in the lab tab, for example, you know, we custom wrote a disclaimer to patients, you know, saying, you know, because we have to release these results to you immediately, your provider may not have seen them yet. And if you think it's going to be upsetting, perhaps you want to wait until your provider's office contacts you, or if it's going to be confusing, you know, again, wait until your provider office contacts you if you want. You know, and essentially it's in your hands to decide when and how you get these results. And so I think, yeah, I think, you know, it's important to sort of bring both physician culture and your patient culture along with you for the ride. Otherwise, I think it can be a lot rockier of an implementation.
Yeah, this is a great point, Jonathan. Thank you for sort of sharing some about the culture of, you know, how you guys were doing this at Geisinger. And I do want to come back to that, you know, just sort of to set the ground kind of even here for some people who may not be along in a sophisticated organization or have as much idea. You know, Jonathan, if you could start, you know, what is the Cures Act? What are we looking at next week? Like, why are we talking about this here today? Like, yeah.
So yeah, in my mind, the Cures Act is essentially delivering on the portability aspect of HIPAA. You know, HIPAA, I think, gets a little misconstrued. Like, I'm a chief privacy officer. I'm not a chief access officer, you know, records access officer, but that's also a huge part of my, you know, sort of compliance oversight activities for this organization. And so I think a lot of folks, you know, HIPAA not only requires privacy and security of records, and that's, you know, a huge amount of it is devoted to that. The other, you know, opposing principle to that is that your record, you know, patient records need to be portable and accessible to them. And I think, you know, after years of, you know, I don't know how else to put it, but, you know, sort of everyone hiding behind the privacy and security provisions of HIPAA, you know, both HHS, as you've seen, you know, you've probably seen all of OCR's enforcement activity related to access to records. And the government basically said, okay, EHR developers, you're writing a bunch of code and protecting your IP, and that's reasonable, but at the same time, you need to create systems that work together if we really want to allow people to bring records with them from provider to provider. And so the Cures Act, I think, is really just solidifying and putting in, you know, clear guidelines on what is expected both from EHR developers, providers, HIEs, and, you know, essentially forcing them to live up to the portability piece that, you know, was passed in '96 under the HIPAA rules.
Mm-hmm. Yeah, and so I guess, you know, with the deadline that's coming up next week, you know, Kelly, Debbie, you know, why are we talking about October 6th? Why, you know, I know Jonathan mentioned USCDI a few minutes ago. What's going on here in a week? Why do we schedule this, this webinar so quickly to talk to everybody here today. What's going on?
I'll kick it off, Kelly. I think that it's been interesting. I want to add in one thing before we move on to that, though. Jonathan made a good point. As a health information professional, I've always been about protecting the information for the patient. And it's a bit of a paradigm shift, I think, for all of us to move from being so concerned about the confidentiality and privacy and protection of that information, which still is very, very important, but at the same time ensuring that access is being made available to our patients so that they have really good information about their own healthcare. It does put them in the driver's seat, which was the intent of the Cures Act. And so when it came out initially, there was that April 5th date, that April of 2029 date, where we had to provide the US CDI. And I think everyone should be somewhat familiar with that US CDI is, United States Core Data for Interoperability. And we had some pretty good specific data points and elements that needed to be made available on April 5th. And we used that as the beginning phases to bring our cultures and our organizations, providers and patients to that point. What's important now, though, is that we're not limited to just that US CDI. On October 6th of this year, just a week or so away, as you say, Alex, we are going to be required to provide what is the designated record set. So it's not just restricted to to the US CDI, it's expanded considerably. And I know that in the past, we have been so focused, particularly in the health information field, about the legal health record and about PHI, but this expands it so much more broadly than just those small areas that we have been focused on in health information. So Kelly, I'll let you take it away from here because I know that we were on a task force together that we can talk about.
Yeah, thanks, Deb. And absolutely. So the big thing with the date is now that the designated record set has to be made available as the data set that you're obligated to not information block and facilitate APIs and EHI exports. It is the same designated record set cataloging and inventorying process that we have done for a long time in the HIM world. Health information professionals have been cataloging like that for quite a while. IT has also been cataloging systems and data sometimes too. But so the designated record set in and of itself does not change with these rules. The definition for that was borrowed from Office for Civil Rights by ONC when they really created the Cures Act and along with CMS. But what the biggest impact is that prior to October 6th, if you had to produce the US CDI, typically you could get that from your EHR vendor. And that was not necessarily difficult to achieve because the EHR vendors pretty much all capturing that data set, certification standards have required it or getting to the point where they do. So, but what can happen in a lot of hospitals and larger organizations understand this, is that part of your designated record set may not reside within your EHR. And those data, and if they're electronic in format, are also subject to the regulation now in disclosure. So it may not be as easy as simply going to one system and gathering information from the EHR. Maybe others have to for how the disclosures also from there. So that's, to me, probably the biggest thing with the October 6th date. Mm-hmm. John?
Yeah, well, I mean, I think one of the big, to your point, well, one sort of opportunity for folks, if you haven't gone through the exercise, is to make sure you clearly define your designated record set. The designated record set has a specific definition, from the OCR rules, but it's also, you get to decide the details of what is in and what is out. And, I highly recommend if you don't have one of those policies, create one so you don't end up in fights with patients and with regulators over what should be in your designated record set. Make sure it complies with the rules, but clearly define what is in and what is out. For example, like our policy, excludes audit trails, like system activity audit trails. And that at least helps us in saying, yeah, we'll give you an accounting of disclosures, but, and we use audit logs for other purposes, for investigations, for, whatever else we need. But the actual raw data, the metadata from these systems is not included in the designated record set. It's not used by providers to make decisions about your healthcare, and it's used for internal purposes. So clearly defining that, and then it also will limit what it'll essentially allow you to clearly define what systems do I need to make sure are providing this in an electronic format that complies with the ONC rules. You can almost use that as your starting inventory of, okay, well, we've got Epic or Cerner or whatever, EHR. What are the other major systems that, maybe billing is on a different platform? How are we going to address that? And you can, start checking off your list, down your designated record set policy to say, okay, yep, we've included everything, or, here's why a subsection is not going to, maybe won't be ready by October 6th, but here's the work we're doing to try to get it ready as soon as possible. I think all of this too, as a former regulator, and I hope ONC takes the same approach, there's a lot of reasonability arguments built into all of these rules, and I think so long as you're showing a good faith effort to comply, documenting the good faith effort. Here's a steering committee. Here's how we've gone down the list. Here's some issues with, maybe your pathology system is on a separate platform. It doesn't have a clear route to, a patient portal. Yeah, that's an investment of $100,000, or, depending on your size, $1 million. And, yeah, that's budgeted, but, maybe that's not included in the October 6th release. Given the enforcement sort of lack of clarity, I think so long as you're documenting those decision points and showing a good faith of, like, we're not trying to block anything, we're just trying to figure out how to actually do this technically. You should be in a good place, but starting with the DRS is, really, I think, the key.
Yeah, and while we're talking about the DRS, I do want to launch a poll here for our audience. So, has your organization defined as a designated record set? So we'd love to hear from you. And, we did have a question about designated record set while we were, while you were talking, Jonathan. They said, this comes from one of our attendees saying, when defining a DRS, should we also define what is not considered a DRS? So do you have to actually say what the exclusions are, not just what's included? So
So not a requirement. I think but I don't think it hurts if you have an idea clearly of what you don't want to be included in the designated record set. So I think in our policy, we essentially said, for example, these things are not included. So audit trails, internal email, like Outlook email between, whatever team, internal communications sort of stuff. And a number of other items, but you can do it either way. I just think it's helpful to, if the way we wrote that piece was, these things are definitely not included. The exclusions may include other stuff that we haven't thought of, but here's at least some examples of what we wouldn't include in the designated record set. I think it's
Jonathan,
helpful
I think you make
whenever
a
you
good
get
point.
complaints.
Yeah, I mean, because you can't do this in isolation, right? It has to be with a larger group because there could be many different systems that could be impacting your designated record set. One example that I could give is outside records. How are those
Right.
being handled? And do you include those? Because if you get down into that meaning of the designated record set, and it's, you know, caregiver decision making, what is being used to make decisions about patients, and it can be pretty broad. And so if you have a system, for instance, sometimes I know some anesthesiology systems, anesthesia or pathology, or some of these other even outside labs, how do you ensure that that's incorporated into your EHR to make it electronically available? And thank goodness we have some exceptions that have been provided to us to allow us to move to those if we cannot provide it.
Right.
Kelly, you want to say something?
Yeah, it's important. You really want a shortcut to do it. Take the task force. Deb and I were on a task force that FAHIMA sponsored that also had EHRA, the Electronic Health Record Association, and AMIA, the American Medical Informatics Association. So the three associations put together a really high-level task force. We worked for 2 years on defining. We first had to educate the group really on what designated record set was and how it worked, and that why we have flexibility by organization. And so anyway, FAHIMA and the other two groups put together a good report on that task force. I'm challenged to remember the exact name of it. Debbie, maybe you do. But look that up, or we will send you copies because it lists what we call data classes. It tells whether they're in or out according to what we as a group thought, but also gave logic behind it and ways to think about whether or not any data class goes in or out. Maybe at some point it's not in the designated record set because it's too early, hasn't been authentic, something like that. And then later comes a part of the designated record set. So
Like appended note, for example.
Exactly.
An unsigned note, and that's one of those callouts we have in our policy. That's, hey, until it's been signed and finalized, it's not part of your.
Right. Yeah, so you can take the task force report, do a job saying, and then adopt it to your policy. We've got policy templates at Compliance Pro for designated record set as well, but I have to say the task force report will help shortcut and give you ideas of what to think of, because it gets confusing with notes and who wrote the note. Was it a scribe? Has it been picked up by the physician and signed off? Those are all kinds of dimensions that you have to think about when you're doing your designated record set.
It's really great. One of the, we have another questions coming in, but I did share while we were talking about the results of the poll, and thankfully our audience here is generally doing pretty well here. About 4/5 have a designated record set defined, which is amazing. Debbie, Jonathan, Kelly, would you say that this is typical of the field, or is this high? What would you say we're sort of looking at here?
Based on my reading, it's high, because if you looked across, I just read an article the other day, I don't really know its scope, but it said in general healthcare facilities, 50% even starting working on it. So, designated record set so high in the list of priorities to do that if you've started your project, you've probably done a DRS, 50%, that's not very good. So I think that's a little high. That's me.
Yeah, and just one recommendation with DRS too, don't confuse DRS with legal medical record, and keep, I would recommend having two separate organizational policies. One is, legal medical record, one's designated record set. They're often have a lot of overlap, but also, each contain different things and are used for different purposes.
We, and you know, to that point exactly, we've got 2 different in our library, one for each, because they are not the same. They
Right.
rely legal record relies a lot on designated record set, I suppose, but it's not the same.
Yeah.
What's interesting is that outside of the health information field, the legal medical record or the legal health record is really not a common term. It's the designated record sets. So it's important to ensure when you're in the health information area that you do have those, I would agree, Jonathan, 2 separate policies so that you know how to refer to those and what is included in each.
Mm-hmm.
You know, part of this discussion about designated record set and about the Cures Act, you know, and I've seen this in some of the other webinars that have been going on recently. One of the big things is the talk of exceptions, so that you're able to use exceptions for this, so that, you know, there are some places where you're not going to be information blocking because there's reasons why, you know, you can't share it. So how do people go about using that? And the reason why I asked is partly is one of the questions that we'll get to in the Q&A shortly, but you know, with these exceptions, you know, is it easy to use this? I mean, obviously with HIPAA, you could just say, you know, the old joke is like, I'm sorry if we don't want to compromise any privacy, but, you know, how do we use these exceptions in that? Jonathan, I mean, I know you talked a little about this the other day, so how can we use these in a responsible way?
Yeah, carefully. and I mean, I think, you know, they really have a high bar to use any of the exceptions. You know, for sort of your provider community, you're probably, you know, the 2 primary use cases for your, you know, sort of physicians and others who, you know, are actually creating the records is the preventing harm and the privacy exception. The key to understanding that is that, again, the bar is extremely high. You should err on the side of providing access to it unless that licensed individual, you know, has a reasonable belief that releasing that record will cause, you know, significant physical harm or death to the patient or another individual. That, I hope that is an extremely rare situation. You know, I think a lot of our providers, and we had to do a lot of coaching, especially, you know, for example, in the behavioral health space and in pathology, to say, you know, mere emotional harm. Well, yes, we need to be concerned about it. You should know about it. You know, that is not a reason for you to block a note from going to the patient portal. You know, I think there's really only one department that we gave, you know, sort of a blanket default to not share, and that was the Child Advocacy Center, you know, within the emergency department. So, you know, essentially, because parents often have an account, you know, if a child comes in alleging child abuse, you know, into the emergency room, you know, it's likely that releasing that record could put that child at risk of serious physical harm or death as a result of the release. But like, that's the others, you know, the default is, you know, provide access to those records unless you can clear that very high bar of physical harm or death to the patient or individual as a result of the release. And essentially both the preventing harm, the privacy exception basically says like you know, if the privacy is violated to the extent that it causes physical harm or death, you know, it's tough for your provider to really choose between the 2. But we certainly gave them that opportunity within the record to, you know, one, they can see, has it been shared online? And if they check a button, they then get radio buttons to choose one of those exceptions and then put in a comment explaining, you know, why it's been blocked.
Mm-hmm.
The other exceptions, you know, are generally, at least from the provider side, are more around, you know, your IT group to you know, and probably for you as you know, if you're in the compliance space, like to go through your checklist. Okay, if someone's telling me they can't make X system available, does it fit into one of these exceptions? And I think one of the things that, you know, gets hammered home by legal experts in this world is if you have to hit every piece of that, every element contained within that exception to make it apply. If you can't hit one of those bullet points, you know, they don't recommend you rely on that exception.
Mhm.
And as we tie this back into the designated record set, one of the areas that I think is very important to all of us is content and manner. Because as we talked about that, if there's something that you are unable to share it electronically, then you can use the content and manner exception to be able to have discussions with the requester of that EHI to identify how you might be able to accommodate them. And you're right, there are all sorts of steps that you can go through from a content and manner perspective to be able to identify how you might be able to meet the intent of the rule.
Mm-hmm.
Well, and I think it's put out there, and I'm not sure who said it first, but right now, you have, with October 6th looming, if you have data that you're not going to be able to share, that's maybe not in your EHR, I believe what we said was content manner exception first. If that doesn't work, then you look at the infeasibility exception. And so, you know, we're trying to get the processes established. It's very complicated. So each of the 8 exceptions has their own conditions, some number of which, as Jonathan alluded to, you have to meet before you can invoke. So I basically call it invoking and revoking exceptions, because I'm not sure that sometimes if you invoke an exception, you may at some point take it off if the conditions get met. But at any rate, it is a fairly complex, will require a checklist, an application, something like that. That's stuff that I've been working on here at Compliance Pro, is how to automate some of this. But you also just have to try to decide which exception is going to work for what case you're trying not to provide EHI or PHI to a requester. You're going to have to figure out the processes for invoking these exceptions, and then again, possibly later revoking them. Who gets noticed? How does it all work? What's your time frame? These are all practices that organizations are just either not yet worked on or just getting to now and figuring out. So if you haven't figured this stuff out in policy and procedure yet, it is something probably on your checklist to do.
Yeah. I want to be mindful of time. We do have a couple of questions we want to get to. Now we have a couple from Lauren and Jennifer on here. I do have two other things I want to just quickly do. I want to send out another poll to ask about people's readiness. While I do that, you know, Debbie, I want to throw this to you. You know, what are some of the practical steps people can be taking here? Obviously, we should be already started. We should be along this journey, but where do we start here? And, you know, right now, I want to ask the audience, like, how prepared do you feel your organization is? But while people are filling that out, Debbie, like, what do people take as their steps? How do we take those first steps forward?
Well, I would say the first step is to read the rule. The second step would be to get a group of stakeholders together to identify who those individuals would be within the organization that could possibly be impacted by the rule. Obviously, in my opinion, it should be the health information area, it should be IT, but it also should be patient access, possibly anyone that would be involved in compliance or HIPAA training, where we can loop some of that individual training in. And then even interestingly enough, some of your marketing individuals to provide some of that patient education that would be required. So go through and really conduct an assessment of all of your systems as you're going through and looking at that designated record set. Look at your policies and procedures to identify what needs to be updated. Obviously, your release of information procedure probably needs to be updated. Look at any of your information blocking possibilities and develop some policies and procedures that need to be done for that. So really work with your stakeholders to ensure that they are collaborating with you. Once you've done all of that and you've identified what your designated record set is, because it's a long process. You're not going to do it in a day. And then start to develop your communication plans, your education plans, and develop your policies and procedures so that you will be able to comply with the rule.
I would say, be sure you work with, if you have a release of information vendor, you're going to need to work with them. It's not necessarily that they're going to do a huge amount differently for some of the requests, but for others it will change dramatically, or they won't handle them anymore. So you have to get in, and they're your business associate. So as a covered entity, you're going to want to guide them, but you have to understand what it is they're doing for others and what they think they can help you with, and how things may change. So do engage with your release information vendor on this subject.
I'll just add one point here, I think, is, IT projects have long lead times like everything else in IT. And certainly, as a vendor, we're working with a variety of providers, and, it takes time to do integrations that need to happen for this to become real as well. So certainly work with your IT team to plan out as you're going through the budgetary cycles for 23, those efforts, and engage the right parties there.
Yeah, that was my last point to get to Harsh. I mean, obviously on the interoperability side, for the IT side, there's a hunger for some of this data, but there's been the challenges. So, where are we seeing this, with companies right now? Are they going to be taking care? Are they really going to be taking advantage of this anytime soon? Are they already in progress of doing that? So where have you seen sort of people find this interest?
I think, two things I'll start with there, Alex. One is, certainly on the journey of compliance is one aspect of this, which is, hey, how do we stay compliant? And there is folks, as Debbie and Jonathan and Kelly mentioned, across the spectrum on that journey. And I think, I think Kelly's number is probably quite close, that, maybe half and half split, I think, on folks that are getting ready. And I think Debbie's comment around companies like Geisinger who are ahead of the curve versus smaller ones that are behind. But one topic that doesn't get discussed enough, which is, going beyond compliance, there is actually business value to be created here. As you build longitudinal records, as folks share the information, and this act is here for a reason, which is to enable that value creation to happen. As more clinical data is shared and more data is accessible and available, there are better decisions to be made across care management. There is better decisions to be made at patient level for their own care. There is a whole lot of spend that happens in exchange of data because it's not exchangeable in a standardized format. That spend affects all of our premiums, that healthcare spend for it to come down. This interchange of data in a standardized format is important. We are very deep with our provider partners as well as our payer partners and health technology vendors, enabling really more focused on, yes, compliance is one piece of it, but actually enabling the value creation that comes with the exchange of data. And I think that's what gets truly people like me excited about, hey, we are doing this for a reason, and let's not seek out the concept of minimum viable compliance, but really truly go get the business value that's out there. So,
well, and as payment continues shifting to this value-based reimbursement model, care management, having a longitudinal view of your patients' chronic care, population management is just, more and more important, and societally the right thing to do. I mean, so long as you, can thread the needle between privacy and access, like organizations that are figuring out how to take this information in and apply it in meaningful ways for their providers, that, and not in a way that's overwhelming. I mean, I think part of the real challenge of this whole thing is going to be one, like we went through the EHI export discussion with Epic on, and went, I sat in meetings and went through 50,000 fields of Epic fields, and their plan is, at some point, like someone's going to be able to hit an EHI export button and get this gigantic machine readable file. How useful that is to a patient, I mean, I'm very skeptical, but someone who does figure out how to take out, probably 90% of the content that's sort of white noise and all sorts of various transaction numbers and things. I think if you can figure out how to ingest it and plug it into appropriate places within your own record, it unlocks huge potential for providers and systems to manage healthcare across large populations.
Great.
I think it's really exciting. I mean,
yeah.
I think it is exciting. My big concern is patient identity. I just think that with patient identity, we're not really sure that you're going to get the right patient. And I'm not convinced at this point that we really have a good way of ensuring that it is the right patient's information that's being shared. And as it's being shared more and more and more with these health information exchanges, or as these QHINs start to move forward with TEFCA, I am, and I know that the Sequoia group is working on that we really need to make sure that we have good, solid integrity with the data, and certainly with integrity with the patient identification.
Yeah.
And I think that what we have to be very cautious about is that increased exchange is going to lead to increased incidents, going to lead to increased pressure on us to arbitrate and to, I don't mean that in a legal manner, but to investigate and to understand, there's going to be now, we're going to be subject to accusations of breach that may have happened from a third-party app that somebody didn't click the privacy notice on, and the information went out. And so we have to be prepared for increasing numbers of incidents to manage and coming from different directions. And so there is going to be, I think, quite a load on privacy and compliance. And I think that we just need to be prepared and watching for that, because I think it's going to be an inevitable result. One of the biggest things with the Cures Act is that it now addresses non-HIPAA entities as well. So they don't have to play by the rules here. The Federal Trade Commission isn't going to enforce them at the level that OCR does, so under HIPAA. So we're going to end up having a lot of information running around out there, and we're going to end up getting pointed back to providers and things like that. So just be prepared just to see what your impacts to your privacy and compliance and HIM projects, things like that may be.
That is a great point, Kelly. And I think, I mean, when you're working on these projects and setting up, whether it's with Epic or Cerner or some smaller vendor, write your own term, like when, at the point where patients can hook up a third-party app, put a big warning up there. You can't block them from doing it, but you can make every effort to say, hey, what happens with your information once you let it go into that environment is not on us. I mean, it is a big concern of mine that, I mean, folks are going to say, why did you let me do it? And it's like, well, we had to, and should have read the fine print sort of thing. But make the print bold that they're making the decision for themselves. And once it's in a third party's hand, it may not be subject to HIPAA. It may not be under their control.
And with that, I was going to say, with that's, sorry, Kelly, with that scary thought in mind, we're going to have to move to the questions and answers. I think we're going to have to do some follow-up webinars, because there's just so much to cover and so much cool stuff. And like, and obviously the privacy and security stuff. So I'm sorry to cut you off here, Kelly, but I do want to get to these questions since we have 3 minutes left. First thing on here, I don't know if this is a question for Jonathan, maybe Kelly or Debbie. First question from Jennifer was, if a patient doesn't have a MyChart account and comes to our HIM office requesting their EHI, since we all have to go into the system and pull that information for the patient like we do today, can we still charge the patient $6.50 for compiling those records? Debbie's shaking her head no. Kelly's shaking her head no. Jonathan's shaking his head no.
Yeah, I think it's a scary route. I mean, right now, I'm encouraging my clients not to be charging patients. And I think their very first thing that they should do is encourage them to get access to the portal, because that's their best way to be able to get the electronic information. And I would be very hesitant in charging a patient if they just say that they don't want to access the portal and they see it's right there electronically. And I think it could be perceived as information blocking if you were to charge that patient for access to their information that is available electronically. I wouldn't do it.
Yeah.
I'll make a quick comment there. I'm sorry to barge in here, but I think, I would tell you that a significant push that ROI vendors and providers are doing is to get people more and more signed up on that portal, and that's a part of change management as well. So, don't wait for it to happen. Kind of aggressively push for people to be signed up.
Yeah,
But
I was going
if they don't or can't, don't charge them for copies. That's the easiest way to keep yourself out of trouble. It's not worth that bit of revenue.
Yeah, I'd say definitely check with your compliance and legal team as well. I mean, I'd heard from another webinar that if you are already charging that amount, you can continue for now, but per everybody else's points about that is the direction we're going to not charge for that. So, but yeah, I think that all makes sense. Next question we have on here, has anyone defined providing records with unnecessary delay? What is that unnecessary delay?
Yeah, John,
It's
I don't
regulators speak.
I mean, right? That's what you say when you don't want to put a real time frame in, right?
Yeah, I mean, for us, to me, it's what are you technically capable of doing? Ours, like the second it's signed or a result is finalized, it's on, within seconds, it is there without delay. Because there was, again, in sort of early conversations with some of the folks who were pretty nervous about, especially like pathology reports, I just don't think if you are technically capable of doing it, once the result is finalized, I don't think you have an argument beyond instant,
Yeah.
And even if it's 24 hours, the actual, or you can point to us if they're like, so in Pennsylvania, for example, HIV results require a face-to-face discussion of those results. So I believe we essentially, delay those results by 48 hours to give the provider time to call, because under the state rule, it requires that to be done first before sending, like a piece of mail, which is when the regulation was written for the PA law. But because there is that extra state law, we sort of said, okay, well, where's a reasonable spot to land? Gives the providers time to make that call and have the discussion, and then it gets released. So you can look at state rules, but it's, I mean, outside of, I think, HIV, there's probably not many other areas.
But it's kind of an attribute when you're doing your designated record set. If there are areas like that are data classes that you should call out, you should probably put it in your inventory. So
right,
you can have a central location for kind of the listing of the designated record set and the other impactful elements.
Yep.
Yep. Well, we are already past time somehow, so I appreciate everybody's time here today. And I hope everybody in our audience also enjoyed this conversation. We do encourage you to follow up with us if you have any further questions. There is also handouts in here, and we will also be sending up a follow-up email with the recording of this, so if you want to listen to us all over again, or if you want to send it to somebody else, as well as the slides and the checklist, that will be coming out in a few days. So appreciate everybody's time. So thank you, Kelly. Thank you, Debbie. Thank you, Jonathan. Thank you, Harsh. This has been great, and good luck to everybody with the Cures Act.
Thank you.
Thank you.